Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hello, listeners, and welcome to episode 55 of Conversations with CEI. My name is Lauren Walker. I direct CEI's Hepatitis C and Drug User Health Center of Excellence. And today we're talking about point-of-care RNA testing for hepatitis C virus. I'm joined by two wonderful guests from the Erie County Medical Center's Center for Hepatology Care, also known as La Bodega. Scott Springer is a certified physician assistant who cares for patients with liver disease and substance use disorders. And Dr. Tony Martinez serves as medical director. He also serves as associate professor of medicine at the University at Buffalo. Welcome, Scott. Welcome, Tony. How are you both doing today?
I'm good. Happy to be here. Happy to be anywhere.
Yeah. Hey, Lauren. Yeah, no, we're doing great here. We have had a lot of rain up here in Buffalo, but it's a lot better than a lot of snow. So we'll take it.
I'll take it. Yeah. Let's kick things off by defining point of care testing. What is that?
I'll jump in. So yeah, point of care testing, generally speaking, is any sort of diagnostic test we can do literally at the point of care where there is a healthcare professional, a peer, interfacing with an individual who's looking to get either screened or diagnosed with something. It's not specific to hepatitis C, but of course it's a huge part of how we screen for and diagnose hepatitis C these days. Kind of more traditional hepatitis C point of care testing focuses on antibody testing. So just checking to see if someone has been exposed to hepatitis C before, but traditionally doesn't include any sort of like nucleic acid testing to check for an active infection. So that's kind of where, new developments and approved technologies are really serving us well in the viral hepatitis sphere.
So I know you kind of touched on that, but how does that differ? Like, what's the innovation here with point of care? What was the prior model of screening for hep C in particular?
Well, the legacy model was really just so many moving parts, right? You had to do the antibody tests and the patient leaves. And then if it's positive, you have to find that individual, get them back, get another lab draw, do the confirmatory RNA testing. So it put all these sort of barriers that now in the new model that we don't need, and it just sort of that legacy model had so many drop-off points where we just lost people. And with the point of care model, basically what we're doing is collapsing that paradigm down into like one visit. I mean, we're essentially, like Scott was saying, we're taking the lab to the patient ultimately. We're taking this diagnostic modality near or at the site of patient care. And the test can be done by anybody. I mean, Scott mentioned a bunch of providers, but it can even be done by the person who's being tested. There's self-administered point of care tests. So you're really bringing that lab to the person and just kind of like eliminating all of those steps in the old model.
Yeah. And I'll say too, like in practice, what this looks like is, prior to, like real-time RNA testing, the only way you would ever be able to initiate treatment in a patient that you're seeing for the first time on a given day is if you have records showing an active hepatitis C infection, where today what we can do in less than an hour, much less in many instances, see someone for the first time, confirm an active infection that needs treatment, and hand the patient medications, which is, like Tony mentioned, all these different drop-off points and barriers. Such a huge win for getting patients started on treatment because that's one of the most challenging pieces of this.
Before it was like a relay race, right? Like constantly handing things off. And now it's just like everything just boom, right from the starting line, it's done.
Ready to go.
Yeah, exactly.
So say I'm a patient, I walk into La Bodega. How does this test work? What does it look like for me as a patient and for you as a practitioner?
Yeah, I mean, it really, it's pretty simple. I think a lot of places that are implementing these point of care tests, especially the newer Hep C RNA point of care testing, a lot of times we overthink it. You have a machine, you set it up, you plug it in, Person comes in, they need to be screened, boom, it's a finger stick blood test, minutes to hours. It kind of depends how high your viral load is, if it's positive to begin with. But you in general have a result in around 35 minutes. While that's cooking, we're looking at some of the other labs that they might have, in the records, whether it's Hep B screening or HIV testing. You get your result, and we in the bodega, we actually have the pharmacy connected to the clinic. So in real time, we just, we discuss with the individual what regimen that they want for their Hep C treatment. We have both on the shelf. Pharmacy comes in with the full course of meds if the patient elects. So we're able to dispense the full 8 or 12 weeks of therapy at the completion of that positive test. So, I mean, the whole thing can happen in literally under an hour.
Yeah, and another big piece of this too is the the updated test and treat rapid start guidelines, because we don't need to definitively know hepatitis B status to start the medication. Of course, we still have to do our due diligence and, like Tony said, do some forensics through the records, or if we do confirm an active infection that we're going to be treating someone, we do have to get phlebotomy to do screening for hepatitis B, to do an assessment for fibrosis using like a FIB4 score. So those are other things that may need to be done in the context of starting treatment, but none of those things are now a barrier to us saying, sorry, we can't give you these meds until we get the results of these labs.
I can't even begin to imagine what the impact has been on the people that you see. Any stories, like what's been the response from folks when they find out this is available?
Oh man, that part's been amazing. I think my favorite story was in the very beginning. One of the first people, when we set the machine up, he was getting tested, and it's a machine with 4 little doors, and he like stuck his finger in the door, and he was like, I just put my finger in here, and then it like tells me. I was like, no, we gotta like poke your finger. But it was kind of funny in the beginning, but now I think the people really appreciate the fact that they don't need to get blood work anymore. The folks that Scott and I primarily see with hepatitis C nowadays, people who, use drugs, and a lot of times they don't have venous access. A lot of times going to get blood work. I mean, even just going to get blood work, because they don't have easily accessible veins, it can be, it can be stigma inducing, right? So you're eliminating all of that. You're eliminating a trip to the pharmacy. And I think a lot of folks now, they still have a little lingering interferon fear from like the old era. And now they kind of see this whole paradigm, how easy it is. They're like, wow, this is it. Like this little finger stick. And now I'm leaving with all my treatment meds. It goes a long way to, I think, build trust and to promote engagement. And this stuff filters out into the street, right? So they go back out and they're like, look, if you go in there, you go to the bodega, it's this easy. This is all that happens. It's simple.
Yeah, I mean, I think one piece of it that I wish I could do more, but I'm really clinic based, is offsite use, outside of a traditional medical context, because it really, it feels like space age technology, right? Like, and I think a really important thing, like Tony touched upon, the stigma associated with like needing to get these blood draws, and what that might stir up in people, but like also the trauma of it. Like, if we don't have to phlebotomize someone and make them feel like a pincushion, I mean, that's such a huge win. And like Tony said, it's like, it's so much more approachable for patients. And I think one thing that, I've spoken about before, that really helps transform some of that kind of like historical trauma of interferon that like hasn't even been experienced firsthand by many people, but still like through generations and socialization with older folks, like the younger folks have that still like in them. And it's kind of a shift from like, we're just going to find that you have this, then give you like a really short finite duration of treatment, almost like, of course, there's still stigma associated with more traditional sexually transmitted infections and diseases, but, kind of just understanding this as, we can just find this. We'll give you a short duration of treatment. You'll be cured. We're going to do what we can to reduce the likelihood that you'll acquire an infection like this again. But most of the time with the resources that we have available to these days, it's not that hard, and patients are super excited about it. So I think just overall that kind of paradigm shift towards like, this is just going to be a brief episode in your life, in your interface with the healthcare system, and you go back out and live your life.
It's funny, like the technology, you're not just diagnosing a disease, right? You're doing three big other things. You're almost like restoring access because you can take it out into these mobile sites. You are restoring dignity because you're making this so much easier and, stripping away so many stigmatizing steps. And you're really promoting momentum in care, right? You're making everything just go that much quicker. And I think all of that works toward elimination. This is the new way toward elimination. But it's pretty remarkable how this simple diagnostic test is served to achieve those three things.
So, folks who are listening, I, full disclosure, had a question to ask about the benefits of point of care testing. I feel that is no longer necessary, but I am required to ask if there are any limitations that we should be aware of.
Yeah, I was gonna say there definitely are like a number of barriers to effectively utilizing, the point of care RNA testing. There's a lot of trial and error when you're first learning how to do the finger sticks. Like, yeah, you're using a lancet, but it's a different technique that many people are used to if they're just doing something like a point of care, a hemoglobin testing, or a finger stick for a glucose reading, a point of care glucose reading. You do have to get a relatively good amount of blood from someone's finger compared to what most people might be experienced to, and that's challenging. Getting the blood that you lance from the fingertip into the pipette that you use, the trial and error, it's mostly error at the beginning for sure. It's something you need reps on, so it's not something that's like super easy to pick up if you haven't done it before. You really need the hands-on experience to do it. I think in my experience, that's probably the biggest barrier and the biggest challenge with it. But I'm sure Tony has some other insights too.
No, I mean, I think you hit on an important one. Point of care testing, it solves sort of the front door problem, right? Getting people screened and diagnosed in one step. But any technology like this is going to come with certain barriers in and of itself. I mean, the cost and infrastructure is a huge piece. This machine and the cartridges, the supplies are not cheap. So that's important. I mean, there's an upfront investment for sure. They're not universally available. Not every place can get access to these necessarily. I think Scott, he just highlighted a lot of the operational challenges, the learning curve. There's staff training that's needed. The workflow into a busy clinic, I don't know, is such a difficult thing, but it is in the beginning until you get that collection piece down pat. There's throughput limitations. If you have a very high clinic volume setting where you're seeing 100 people a day, maybe this isn't, your horse, right? It may not work there. There's reimbursement issues. There's only a handful of states where you can actually reimburse for doing the testing. So, a lot of times you're doing this with a lot of clinical benefit, but there's no financial break-even point. So that's a factor. And it's obviously not a complete care solution, right? I mean, this is just the diagnostic part. We talked a little bit about, do you need Hep B screening labs? Do you need HIV testing? As it stands right now with this machine in the US, based on its FDA guideline, it's also not officially approved for SVR assessment. So there's definite limitations. You need a strong system behind it and a good infrastructure. And I think another piece that's really important is that you need to be aware of your state limitations. We still have states throughout the United States that, if you're listening to this outside of New York, you need to be aware of before you go and invest in this. If your state and your CMS or some of your payers, based on your patient mix, don't allow point of care testing for access to medications, this may not be the way that you go. Because if you still need antibody and confirmatory RNA, if they don't accept point of care at all, you're going to invest in this and you're not going to get very far with it. It'll be good for patients to know, but it doesn't mean that you're going to get them through that patient journey any quicker. So I think all of those things have to be taken into consideration before you embark on this stuff.
Yeah, and Lauren, I don't want to jump the gun if this is something you were planning on discussing later, but I mean, after hearing Tony talk about all these kind of more macro kind of systems-based limitations, I mean, I think the important thing that it brings to mind for me is that, of course, the point of care RNA testing is the cutting edge. It's like the tip of the spear in what folks like Tony and I are excited about. But, it highlights the fact that there are other more long-standing, well-established point of care tests like point of care antibody testing, dry blood spot testing that, still have clinical utility. And depending on the setting that you're trying to use these, or if point of care RNA testing is out of reach or not feasible for any number of reasons, it's still valuable to have these for people. So, it's important not to lose sight of that. Like, this isn't the end all be all. It's an amazing tool that I think will get us closer than we've ever been in this country to eliminating hepatitis C. But, there's still plenty of folks who can benefit from, what we had before this machine.
Yeah, that's a really important point that Scott just made. I talk about this around the country all the time. I always say the same thing. The best test to use is the one that you've got. It's not that the tests that we had before point of care RNA testing were bad. It's just that sort of the paradigm of screening and diagnosis didn't really evolve along with the therapeutics. So we went to these really easy to use therapeutics, and the rest of it, the infrastructure piece, still kind of lagged behind. If you have a point of care antibody test, and that's all you've got to use, it's still great. DBS is funny because it's not truly a point of care test, right? It's done at the point of care, but the results come farther down the line because it has to be sent in. So, but if you're getting them from free, through your local DOH, and that's what you've got, that's awesome. If you're a methadone clinic that can't draw blood, for example, but you have access to DBS testing, that's absolutely the one you should use. If you're still doing conventional phlebotomy, even, it's not that it's bad. It's just that we, in that setting, really have to focus in on reflex testing and just eliminate the standalone antibody. But none of those tests in and of themselves are devalued by this at all. This is just sort of the next part of the evolution. And if you've got access to it, it's great. But if you're still using some of those other tests, there's absolutely nothing wrong with that. Such
a good point. I feel like all the time we have new innovations coming, new things in the pipeline. Everyone gets really excited, and we forget that, your landline phone still works just as good as the phone that is in your pockets.
Yeah, exactly.
I feel like we've kind of closed out the conversation. Scott, you did not jump the gun at all earlier. My only lasting question, is there anything else that you want to leave our listeners with today, or any other experiences about using this at La Bodega?
Well, I think for us, it's been, it's part of our natural evolution. We've been using it for a long time now, and we've always sort of operated on this rapid start model of care, but this has enabled us to deploy a true test and treat model of care and not a modified version of that. But, I think the bigger overarching point would probably be that if we're really serious about eliminating Hep C, we can't expect patients to navigate a fragmented system. Whether you have point of care RNA testing, whether you're doing phlebotomy, you really have to find a way to just streamline that cascade. In this situation, the point of care testing, it flips the model. It really truly meets people where they're at. It delivers an answer in real time. And I think it opens the door to creating a pathway to cure in a single encounter.
Yeah, I mean, agreed. The single encounter piece is huge. Like, of course, a small percentage of these patients may need longer term follow up in, a hepatology setting. The vast majority do not. I think what, reflecting on this discussion and kind of over my career and the other changes that have taken place in the relatively short amount of time I've been practicing, is that I think it's really important that we don't lose sight of the bigger picture of what we're really doing here. And as we're engaging more people in hepatitis C treatment, this isn't some, like cure-all silver bullet for hepatitis C. The work still needs to be done to find these patients, to be tested at the point of care, and to be given medication in a timely manner. And while, as exciting as this is, and it's amazing seeing what others around the country and the world have done with this technology, always my fear is I go to these liver conferences and I have people in hepatology that say, "Oh, I thought we solved Hep C. Isn't that all fixed and all done now?" And the reality is we're not a whole bunch closer. We have more promising treatment guidelines and society recommendations and technologies, but like the work still has to be done. So please don't lose sight of that. If you're not active in the Hep C space, this isn't like, "Oh, we've got it done now, guys. This is fixed. We've got it." It's not at all. So it's important just not to lose sight of that piece, because in some of these more detailed niche conversations, that piece can be lost. So don't lose sight of that.
Just another tool in the toolkit to continue the work that we are all doing.
Absolutely.
Well, thank you both for joining me. Thank you for participating in Conversations with CEI. It's been a total pleasure.
Absolutely. Always great to see you, Lauren.
Take care, everybody out there.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.